challenges to interdisciplinary pain management, inconsistency how programs manifest interdisciplinary practice, and not realizing. And I think that's part of the reasons why they make that distinction between multidisciplinary and interdisciplinary at the beginning of the article. A lot of folks will assume that multidisciplinary means they're actually interdisciplinary or integrated, and they're not, because it's that communication by whatever vehicle, asynchronous or synchronous, and in a truly shared treatment plan that everyone's participating in. So now the other part is, and I mentioned this already, is getting health plans to cover these functional restoration programs in particular, but even longer term outpatient care has been quite a struggle, certainly in facility-based care, and frankly, that, now this is my opinion, not from the article, but that's actually markedly worse than it was at the time of this publishing. The last, since the change in administration, it's the challenges of dealing with insurances have, at least from my perspective, have gotten worse. More administrative denials, more administrative burden than there was a few years ago. Now, here's a, my opinion, not the author's assertion necessarily, but here is a classic example of the counterintuitiveness of our healthcare system. So interdisciplinary pain management, we just saw lots of different data points on how this improves outcomes, it saves money, and when we use these programs in the context of our military, actually improves our fighting force, our readiness, and our national security. Nonetheless, because of the upfront costs, we have seen a significant decrease over the last number of years. The number of programs like the ones listed a few slides back have decreased by, they're terrible at math, but we're looking at less than a fourth of the number of programs than we had about 20 years ago. So so bringing it back to policy, there is lots of opportunity for policy advocacy here, and lots of good data to support why we should, from a policy perspective, mandate that these programs be available and accessible. So, other challenges to interdisciplinary chronic pain management. A lot of these are the same as many others. Certainly, all the same, sadly, all the same kind of fault lines of disparity and structural oppression apply in accessing pain management, as it does accessing almost any type of healthcare. So that is another point of advocacy. Just like just about every other aspect of care, people who live in more rural areas of our nation, particularly impoverished, more lower socioeconomic and impoverished rural areas, have the least access to, in a lot of ways, in many instances, and certainly not just uninsured, but the underinsured, right? So we have n number of millions of uninsured, and now we're looking at significantly more people uninsured in the current national and global circumstances, but that doesn't even touch the vastly many more tens of millions of people who are underinsured. What do we mean by underinsured? People who have a plan with a several thousand to $10,000 deductible, right? That's great if your health plan will pay for you to go to a semi residential pain management functional restoration program at the Mayo Clinic. But if your deductible is $10,000, the likelihood that that's acceptable to you, not acceptable, but accessible to you, is pretty much like, why bother authorizing it if there's a $10,000 deductible, or even having the insurance in the first place? So that's Paul's definition of underinsured, not necessarily anybody else's. Um, Recognition by primary care providers to get people into specialty care, including interdisciplinary and cognitive behavioral therapy care as part of pain care. Now that and in partly for the purpose of not making this total doom and gloom, I can tell you from my own experience that more and more a source of referral in my private practice are primary care offices and pain management specialty clinics who are referring to me to be a part of their pain management care. Now, they don't necessarily, they're not super willing to talk on the phone or even kind of correspond by secure fax communication, that kind of thing. If I push on it, they'll sometimes respond, but not always. But at least they are recognizing that, hey, let's get this part of the care involved and have this person getting the CBT part of the treatment along with what we're providing in primary and pain specialty care. So I do take that as a good sign, and it does help. It definitely